pleasure to be here on this beautiful Saturday morning to talk about new advancement in oncology. And I have to start by saying that I was very moved by Suzanne's story of survival. And she's living proof that spending all those sleepless nights at home studying for the boards and studying in medical school, all those nights are paying off, knowing that you can do something with this medical knowledge and you can help patients live longer and enjoying their lives. So thank you, Suzanne, for sharing your story with us. I'm going to touch a little bit on advancement in medical oncology. I have to say it's very exciting to practice in 2014. And it's exciting because of all these new advancements in drug development, in the concept of a multidisciplinary approach to patients. Talking about new cancer drugs, back when I started practicing 15 years ago, we only had 5-FU. And Suzanne touched on that. I remember being taught of using 5-FU in different schedules. You know, first we use it weekly. If weekly fails, you go to continuous infusion. If continuous infusion fails, you go to every other week. And so there were all these different variations of using 5-FU. Nowadays, we have at least 8 new drugs that were approved in the last 15 years, which again makes it very exciting because we were able to quadruple the lifespan of patients living with advanced colorectal cancer. The other new thing is the concept of personalized medicine. So what I mean by that is that we're trying to understand different tumors, what molecular mechanisms are activated in different tumors, and tailor our treatment specifically. And there are different examples. For example, that is applicable for lung cancer, where we have invented EGFR pathway that's activated in some patients. And you know, that leads to use of a specific medication with Tarceva. The same is true in colorectal cancer, where we look for KRAS mutation to know if certain patients would benefit from medications like cetuximab or not. There are also labs in Arizona that look at all the activated genes within a tumor and try to identify what particular drugs might work for that person based on those pathways. And that lab is Caris. You might be familiar with that. In the future, it's predicted that we will not treat cancers based on the cell of origin. So we are not treating lung cancer as lung cancer, colorectal cancer as colorectal cancer, but we'd rather treat cancers based on the genetics involved and the molecular pathways that are activated. In addition to this, we have a new set of treatments, the biological therapies. So these are not chemotherapies that attack all rapidly dividing tumors, but there are drugs that target mechanisms that are important in tumor growth, such as neovascularization, creation of new blood vessels that feed the tumor. And you probably heard of Avastin, which is a drug that's a biological agent that, when given in addition to chemotherapy, significantly improves the response rate as well as the survival. So all these, the availability of all these drugs makes treatment so much better. What is cancer? Cancer is an uncontrolled proliferation of a cell. Cancer cells have the ability to locally invade in the surrounding tissues, and they also have the capability of spreading through the bloodstream to other sites and causing metastatic disease. Different cancers have different types of spread. Some cancers like to spread to the lung, some cancers like to spread to the liver, and these define a certain natural history of a cancer. What I mean by that is rectal cancer, we know usually spreads to the lung. Colorectal cancer likes to spread to the liver. Sarcomas like to spread to the lung. The metastatic potential of a tumor depends on certain factors, primarily stage of the cancer, but also grade. How aggressive does this cancer look under the microscope? And particularly the genetic composition of the tumor. Again, the metastatic potential depends on those genes that are activated within the DNA material of a tumor. Liver metastases are seen in a variety of tumors: colon cancer, breast cancer, lung cancers, melanomas, carcinoid tumor. From a medical oncology perspective, we want to treat these patients with systemic chemotherapy because the thought is the way the metastatic disease occurred to begin with is through spread of the cancer cells through the bloodstream. Therefore, it makes a lot of sense to give the patient something that goes into the bloodstream and kills all those microscopic cancer cells, in addition also killing the liver metastases. Like mentioned previously, there's been a lot of progress in the era of chemotherapy, with new drug development, with combinations of chemotherapy agents, combination of chemotherapy with biological therapy. This is the timeline for colon cancer chemotherapy. So in 1970, we had 5-FU, which was given in different schedules. 1996 marked the first new drug that was approved for colorectal cancer, that was CPT-11. And following this, there's been an explosion of new medications. Xeloda, which is an oral 5-FU prodrug, oxaliplatinum, a new platinum agent. In 2006, we started having this multi-chemotherapy regimens, the FOLFOX in combination with Avastin. Soon afterwards, FOLFIRI in combination with Avastin. In 2006, we started having EGFR-directed treatment, Erbitux as well as panitumumab. And then in 2012, we started combining those with a chemotherapy backbone. And then in 2012, just 2 years ago, we added 2 new biologicals to the chemotherapy regimens. Liver-directed therapy. I wanted to share some of my thoughts where these treatments might be useful from a medical oncology perspective. We see these treatments as adjunctive modality to chemotherapy. So we always want to use a systemic chemotherapy to prevent new metastases. But in addition to this, we want to target the liver itself. I think it's very indicated in patients with liver-predominant disease, patients with a good response to chemotherapy who have persistent disease in the liver, patients with isolated liver metastases who are not candidates for surgical resection of the liver metastases, and also indicated in patients who have extensive chemotherapy treatments and are refractory to chemotherapy, who now have progression in the liver. And I wanted to share a few cases with you. These patients had a great response to liver-directed therapy. These are cases that I worked on with Dr. Nutting. The first patient, a 70-year-old male who was diagnosed with metastatic colon cancer in July 2011. He presented with right upper quadrant pain. He saw his primary care physician and had a workup with ultrasound, CT of the abdomen, and eventually PET scan. And the PET scan showed that he had increased activity in the colon, in the sigmoid colon. He had regional lymphadenopathy and also very extensive disease in the liver. He had a biopsy of the liver which showed metastatic colon cancer, KRAS wild type. He was seen by the surgeon, and because he did not have an obstructive lesion, it was not recommended that he have surgery on his primary tumor. So the treatment that was recommended was chemotherapy. He had a very good response to the frontline treatment, which is FOLFOX Avastin, and he continued this for a full year. By the end of he had clinical response, and by that I mean his right upper quadrant pain improved, his CA level went down, he felt very well, and he was very functional. About a year later, he started having some peripheral neuropathy symptoms from the oxaliplatinum, and we dropped the oxaliplatinum and continued him on 5-FU Avastin. He did well for another about 6 months, and then he started having a rising CEA and a worsening scan. At that point, we started him on second-line chemotherapy, FOLFIRI Erbitux, and again, he had a very good response. He had very chemotherapy-sensitive disease. He did well until end of February 2013, and at that time, again, he had a rising CEA. And at that point, regorafenib was just approved for third-line treatment, so he was started on this agent. A scan at that time showed that he had liver-predominant disease. So this is his scan that shows liver-predominant disease. This is a cross-section here. The same thing here. whereas before he only had a small amount of liver metastasis. So because he had liver-predominant disease, we thought it would be a good option to proceed with liver-directed therapy, and we referred him for radioembolization. So again, the key thing is that the PET scan showed progression of the hepatic metastatic disease, and there was no other disease activity outside the liver. Again, the patient had already received the most active chemotherapy, so we wanted to improve his response rate with the radioembolization to the liver. He was treated on February 8, and he had a very good response to treatment. And I have a follow-up scan that shows an improvement in the activity in the liver. And again, a normalization of the uptake in the liver. So this is a patient who has received the most active agents up front. He had progression. It was primarily localized in the liver, so it made a lot of sense to treat him with liver-directed therapy. The next case I want to present is a little different. Although he presented in the same manner with right upper quadrant pain, and his story was unusual. He went to the doctor complaining of bronchitis and was started on antibiotic therapy. And during that visit, he also had blood work done, which showed that his liver functions were off. So additional workup was recommended. He ended up having an MRI of the liver, and this showed too numerous to count liver lesions. Biopsy of the liver mass showed adenocarcinoma of the colon, KRAS mutated. So it's important that this was mutated because that means he will not have a lot of benefit from cetuximab therapy. He had a PET scan which showed the increased activity in the liver, but also increased activity in the transverse colon, where the primary was. Colonoscopy did not show an obstructive tumor, so the recommendation was to proceed with systemic chemotherapy. And he was also started on the most active regimen, the FOLFOX Avastin, and then after he reached some neurotoxicity from the oxaliplatinum, we dropped the oxaliplatinum and he continued with 5-FU Avastin. The repeat PET scan showed a very good response, but he had some residual disease in the left lobe of the liver. And he was actually did a lot of research on his own, and he wanted to obtain a CR, a complete response to treatment. In fact, he went to a talk like this, met Dr. Nutting, made an appointment to see Dr. Nutting, and we discussed about converting him from a partial responder to a complete responder by using the radioembolization procedure. So what happened is, in November, he was treated with radioembolization to the left lobe of the liver where he still had some persistent disease. Follow-up PET scan 3 months later showed improvement on the left, but progression on the right. But again, there was no other disease elsewhere. So we did radioembolization on the right. And again, 3 months later, a repeat PET scan shows improvement on the right, but some mild progression on the left. Again, with no other disease elsewhere. So we decided for the third time to repeat the embolization to the right lobe. And we were able to control his disease like this for about 9 months with very good quality of life. This patient was always on the go on different vacations across the country. This is a picture, but it doesn't unfortunately project that well. But anyway, this shows his picture after the second embolization, where the liver involvement on the left is better, but he has some progression on the right. So in conclusion, there's been a lot of progress in treatment of metastatic cancers, and that's based on improvement in chemotherapy regimens, addition of biological therapy, the multidisciplinary approach to patients, and definitely a liver-directed therapy that has led to an improvement in response rate and a prolonging of the patient's survival and quality of life.